Hasif.
Okay, saya.
Nampak tak slide?
Nampak?
Okay, thank you.
Nampak ke?
Nampak?
Nampak.
Nampak.
Boleh nampak, boleh nampak.
Hi guys.
Doctor?
Can hear me, no?
Yes.
Yes.
Can hear.
Yes, Doctor.
Is it clear or not?
Yes.
Because I'm using my phone. I'm on my hands free. If you hear noises in the background, it's my 2 kids making noise. Okay, so just ignore.
Alright.
Not everybody's here yet, right?
Yeah.
Yes.
Why me? Why you want to say hello? No. Okay, say hello and then bye-bye. Bye-bye. Mommy has to work, huh? Okay, bye-bye. How many are supposed to be here?
Yeah.
How many participants? Huh? Sorry?
Supposed to be 38.
28.
38.
30,
Yes.
38. Sekarang berapa orang je? 20 lebih kan tadi?
35.
Sekarang about 34.
Okay. $35. Supposed to be 38 kan? Lagi 38 including me or 38 for your class? Who's supposed to be with me on Thursday for long case? Guys,
Group
This-
3, Doctor.
Group T.
group C.
3.
Three.
The long case is you guys supposed to present, right?
Yeah, supposedly like that.
Okay, so how many presenters you wanna be? You wanna have? You can have 2 because it's just a long case kind of thing. you can have two. You just tell me in advance what the presenter can just tell me in advance what the diagnosis is, and I see whether I can drum up something to let you guys see lah. Okay nak?
Okay.
Siapa kumpulan ni? Siapa kumpulan 3? Okay?
Okay.
It's only that group, right?
Yep.
So I think you prepare 2 cases, but the presenter tell me beforehand what cases they are so that I can just see whether I can drum up something for you guys.
Alright.
Okay?
Okay.
Okay.
Okay,
Now,
Doctor.
I see still got 35 participants ni. Tak cukup lagi kan? 36. Lagi 2 orang kan? Nak tunggu ke nak start? Okay, anyway, third years kan?
Yes.
Betul kan?
Yes.
Kalau if you want to read a book about development, there's this book. It's like black and white, and it's like nipis. It goes by age lah. It goes from 0 to 5 years old. It's only about 90 pages or so of this type of writing. See, it goes by age, and it goes by whatever components it is. So see whether you have it in the library. If you have it in the library, just photostat since it's black and white anyway. It's Mary Sheridan from birth to 5 years. Okay? If you guys want to read lah. If tak nak, then tak apa. Okay?
Okay, Doctor.
Thank you, Doctor.
If you ever come across this book, I don't think they print it anymore. You ever come across this book, then it's quite a good book, but you need to read your textbook first before you read this, because it's like kind of like short notes, 1 page per system and 1 page per diagnosis kind of thing. Okay? Okay. Want to start yet, or you still want to wait for the? How many more people? 38 already.
One
One
people
person
left.
Just want to start or nak tunggu? Start je lah. Okay, start.
Okay. Good afternoon to Dr. Chan and fellow friends. And today, me and my friends will present a seminar about the topic of virology. So my part, I will discuss about infectious mononucleosis and Roseola infantum. This will be the output for everything started with etiology, epidemiology, pathogenesis, clinical presentations, complication investigation, and also management. So overview for the disease infectious mononucleosis. It is typically infectious mononucleosis will cause a clinical syndrome like fever, limb adenopathy, and also tonsillar pharyngitis. And the primary cause is usually because of Epstein-Barr virus. And the mode of transmission can be caused by orally, which is by saliva, which is
Aku je kan di snack ni semua
I cannot hear your voice.
semua hilang.
Maman disconnect tau.
Mama disconnect.
Bukan aku Okay.
Presenter got disconnected, is it?
Yes.
Yes, Doctor.
Why don't we just do the second one first then? Anyway, well, is he still sharing the screen?
No.
No,
I think
totally
he has.
gone.
I think he has internet problem
You guys in campus or at home?
at home.
At the home, Doctor.
Home.
Tak masuk campus lagi?
Belum.
Lagi.
Okay. So long case tu macam mana nak present?
Usually doctor will give case scenario.
Okay. Then if I give case scenario, okay lah. Then you guys just bring your ears near.
Sorry, Doctor. There are some connection. Where are we just now?
Sambung
EBV,
dari tadi. EBV.
Yeah.
Epstein-Barr virus.
Okay.
Transmitted by saliva. You guys know why it's called the kissing disease, right?
I'm sorry?
You guys know why? You guys know why it's called the kissing disease, right?
Yeah.
Yes.
Mode of transmission.
Yeah. You know why in the US lots of teenagers get it one after another, right?
Yeah.
Yes.
Yes, because they start dating, start kissing, isn't it?
Yes.
Okay.
So
Continue.
the mode transmission usually by orally via saliva, which is the person to person, because the virus can shed in the saliva at high level for a long time of period. So it can be demonstrated by kissing, which is why it's called kissing disease, or also can call glandular fever. And also it can cause by sharing drinks and foods, sharing toothbrush, food utensil, and also cups, and also having contact with toys that the children have drooled on. So, and in infectious mononucleosis, rarely breastfeeding, sexual transmission, and also blood transfusion, and also organ transplant, the mode of transmission. And majority of infection in children is subclinical, which is asymptomatic, and about less than 10% can cause clinical infection. So usually infection mononucleosis is asymptomatic. So the etiology is it is caused by Epstein-Barr virus, which is the herpes family, human herpes virus 4, HHV4, and the virus composed of double-stranded DNA, the double-stranded DNA here, and also surrounded by nucleocapsid and glycoprotein. And humans are the major reservoir for this virus. And also there is other condition or other disease which can cause mononucleosis-like syndrome, which is minimal pharyngitis, pulmonary splenomegaly, and also often present with fever only. However, these other infections cause heterophile negative infectious mononucleosis. Heterophile negative, which means usually Epstein-Barr virus infected infectious mononucleosis will produce antibody called heterophile antibody. Heterophile antibody is an antibody produced which the antibody will actually agglutinate with other things except for Epstein-Barr virus itself, which why it is called heterophile antibody. So usually infection mononucleosis will produce heterophile antibody. However, in other diseases which can cause mononucleosis-like syndrome will not produce heterophile antibody. So the other diseases include cytomegalovirus, which can cause minimal pharyngitis and lymphadenopathy, Toxoplasma gondii, hepatitis B and C virus, and also human immunodeficiency virus, HIV. For the epidemiology, Epstein-Barr virus usually infects more than populations, mostly have seropositive to ABV. Mostly the population of the world will have the seropositive to Epstein-Barr virus, but we do not know we have the infection because it is usually asymptomatic. And most common, it is in early childhood with a second peak during late adolescence. And it is disease of young adults, peak age around 15 to 24 years old because of the kissing. And usually in developing countries, the EBV tends to infect children at early age, and infectious mononucleosis is always uncommon. And in developed countries, infection often delayed until adulthood, and infectious mononucleosis always more prevalent in developed countries. For the pathogenesis, usually Epstein-Barr virus will have particular tropism for B cells and epithelial cells of the pharynx. And firstly, the Epstein-Barr virus will attach to and infect the epithelium of the throat, which is the oropharynx, and it will be replicate and will cause pharyngitis. And also, the replication of the virus in the oropharynx will spread to the oropharyngeal secretion, which is saliva, and that's the cause of the mode of transmission, which is via the saliva. And then next, the virions will enter the lymphatic vessels and are carried to the lymph nodes or others reticuloendothelial system like spleen or liver. And some of virions will escape the lymph nodes and trap and also can be carried to the bloodstreams. This is how when the virions can escape the trap of the lymph node and carry it to the bloodstream. This is how the systemic symptoms like fever and malaise can come. And the next one, the virions will then attach specifically to the B lymphocytes and infect them and can produce either latent or productive infections. The infected B lymphocyte actively will replicate and differentiate into cells producing random immunoglobulin, including heterophile antibody. This is how the heterophile antibody can produce. And we take note that that cellular immunity much more important than the humoral immunity in controlling EBV infection. This is why T cell is very important to eradicate these viruses, as T cells will respond to the infection and destroy the lymphocytes replicating Epstein-Barr virus. However, there is the Epstein-Barr virus can be latently infected B lymphocytes and become immortal. They are not attacked by any of the T cells and remain latent. So the clinical manifestation of infectious mononucleosis, it started with incubation periods for about 4 to 8 weeks. And then after incubation periods, it will cause a symptom which is known as classical triad, which include lymphadenopathy. Mostly will have lymphadenopathy, which is usually most common in the post-cervical and submandibular lymph nodes, and less commonly involve the inguinal and axillary lymph nodes. And this lymphadenopathy usually tender and symmetric and not fixed in place. And next one is fever, which around 95% will have fever, which the fever is low grade and may persist until 1 month. And the next one is pharyngitis, which is enlarged tonsils with exudates and inantum with pharyngeal petechiae, as you can see in the picture. And there were also symptoms and signs like body aches, fatigue, and also swollen tonsils. And patients with infectious mononucleosis can also present with splenomegaly, about 50%, and hepatomegaly, about 10%. This is due to the immune response of the virus, of the immune response. And then some patients also can have amoxicillin rash. What is amoxicillin rash? It is a rash, widespread erythematous macular rash in about 80% of patients with infectious mononucleosis, which are treated with oral ampicillin. This rash can occur because patients will come to the doctor with complaint of fever and also pharyngitis, and the doctor will suspect the patient will have bacterial infection. So the doctor will give amoxicillin or ampicillin to the patient, and it will cause rash. And the complication of infectious mononucleosis include death. However, it is rare And the deaths usually occur due to CNS complication, spleen rupture, upper airway obstruction due to the pharyngitis, and also bacterial superinfection. And autoimmune hemolytic anemia can also occur in 2% of cases during first 2 weeks. However, this is rare, and the pathogenesis is also not understood yet. And there will can also non-specific antibody response may also include rheumatoid factor, anti-nuclear antibodies, anti-smooth muscle antibodies, anti-platelet antibodies, and also cryoglobulins. And spleen rupture can also occur in less than 0.5% of the cases if the patient is not careful. And also peritonsillar abscess or airway occlusions secondary to edema of the soft palate and also tonsils. So investigation that we can do in infectious mononucleosis, the first one is a blood investigation, which is the full blood count. We can see there will be an increase of white blood cell count in the second and third week of illness. There will be increase in the lymphocytosis, and there will be 10% of atypical lymphocytes, which is the numerous large T cells seized on the blood film. And also thrombocytopenia. This is the picture of the atypical lymphocytes, which is bigger, numerous large T cells. And the next one we can do is the monospot test, which we use to detect heterophile antibodies. It is 75% sensitive and 95% specific. As I mentioned earlier, the heterophile antibodies not interact with the ABV proteins. And the titer of more than 40 is diagnostic and not reliably positive in children less than 4 years old. Usually children less than 4 years old, even though he or she have the infection mononucleosis, the heterophile antibodies will be negative. We can use also serology to confirm the diagnosis of infectious mononucleosis, which we can use to differentiate between acute and also previous infection. We can check the viral capsid antigen, IgM, which can indicate acute infections, and also viral capsid antigen, IgG, for previous infections. And also we can check for Epstein-Barr nucleic acid IgG also. This is, we can see IgM and also IgG, the viral capsid antigen, and also IgM viral capsid antigens, which IgM, it will increase first and then the IgG. And we can use nucleic antigen just now, EBNA, IgG to check for freezer infection also. For the management, usually management for the infection mononucleosis is mainly supportive. We can give treatment like fluid for hydrations, rest, and also acetaminophen or ibuprofen for pain and fever. And also we should avoid contact sports in patients with splenomegaly because to avoid any splenic rupture. We can also give short course of corticosteroid for patients with airway obstruction due to tonsillitis and pharyngitis, and also hemolytic anemia, and also if there is any CNS involvement. And we should avoid ampicillin or amoxicillin to avoid the generalized rash caused by the drug itself. The next one is Roseola infantum. The first one, I will explain about the overview. The Roseola infantum, or also known as infantum subitum or sixth disease. It is acute self-limiting disease in infancy and also early childhood around 9 to 12 months. Usually the Roseola infantum will characterized by 3 to 5 days of high fever, can be more than 40 degrees Celsius. And then after the fever have gone, it will followed by appearance of generalized maculopapular rash. And primary cause usually is caused by human herpes virus 6 and not commonly by human herpes virus 7. And the mode of transmission also caused by oral and respiratory secretions. For the etiology, human herpes virus 6, it is caused by human herpes virus 6. It is a family of herpes viridae and subfamily by beta herpes virinae. and the genus is Roseola virus. The virus composed of large and enveloped double-stranded DNA, as you can see in the picture, and also it is composed of icosahedral capsid and protein-dense tegument, and also the lipid envelope, which is the viral glycoprotein. For the epidemiology, Roseola infantum is usually the transplacental antibody protects most infants until 6 months of age. And the incidence of infection will increase as the maternally derived antibody levels will decline. And 95% children being infected by 2 years of age. And the peak age of primary HHV6 infection is 9 to 21 months of life. And Roseola occurs equally in boys and girls, and it occurs throughout the year. And the virus is likely acquired from asymptomatic adults who periodically shed these viruses. For the pathogenesis, the HSV6 occurs when a person comes into contact with respiratory or oral secretion from another person who contain the virus. And once in the body, the virus will attach to the dendritic cells, which is the antigen-presenting cells. And then these cells will process the antigen and present them to the T cells. And then it can activate the T cells, then migrate to the lymph nodes and where they interact with the CD4 positive T lymphocytes. When the dendritic and T cells interact, the virus get ingested by the T cells and the T cells get infected. So inside the T cells, virus can actually replicate more efficiently. It undergoes a lytic cycle where DNA gets transcribed and translated to form viral protein, which are packaged into new viruses and which the cell will be destroyed and subsequently infect neighboring T cells. So actually this viral will use the T cell for its replication processes to be occurred. Unlike the Epstein-Barr virus, it uses B cells. For this virus, it will use T cells to replicate itself by using the lytic cycle. And then after it infects the T cells and do replication, it will destroy the cell and infects another neighboring T cells. And it also can infect other cells like monocytes, macrophages, and also other cells. And after they infects other cells, lymphocytes, it will cause viremia 3 to 5 days in peripheral blood mononuclear cells. And finally, the HSV-C can establish latency in the blood mononuclear cells and other sites like salivary gland and also CNS. And people with immunosuppression, the virus can be reactivated and can cause severe infection like encephalitis. For the clinical manifestation, it started with incubation period about 1 to 2 weeks. And then after in the incubation period, it will present with high fever, usually more than 40 degrees Celsius, about 3 to 5 days. And then in the febrile phase, the patient will have upper respiratory symptom, nasal congestion, erythematous tympanic membranes, rhinorrhea, which is runny nose, cough, malaise, GI symptoms like vomiting and diarrhea, and Nagayama spots, which is the red spots that we can see in the soft palate and also uvula. And after the fever, there will be maculopapular rash or rose, and maculopapular rash is rose colored and non-pruritic, and it's about 2 to 3 millimeter, and it will blanch upon pressure, and it will occur around 1 to 3 days. The rash usually occurs started in the trunk and neck and will spread into the extremities. So this is a picture on the differences between the rubella, and also Roseola infantum, which I just explained about the Roseola infantum. So the complication of Roseola infantum includes acute febrile convulsion, which is the most common complication with the primary HIV infections. people with immunosuppression or with bone marrow transplant can cause reactivation of the virus and will result in encephalitis and also hepatitis. So investigation that we can do, usually non-specific because usually this Roselia infantum we can do only clinical diagnosis. But we can do investigation like CSF, which is cerebrospinal fluid analysis in encephalitis patients, which we can see pleocytosis and a slight elevation of protein and with normal glucose. We can use also serology to detect antibodies to the HSV6 and HSV7. And also we can use polymerase chain reaction, PCR, which we can detect the HSV6 DNA in the blood or even in the CSF. For the management, since it is only self-limiting, so there will be no specific therapy for Roselia. It's only requires supportive care like fluids, to maintain adequate hydration and rest, and also acetaminophen or ibuprofen for pain and fever. In patients with immunocompromised or in severe manifestation, we can also use antivirus therapy like ganciclovir and also foscarnet. And usually the prognosis for this disease will cause an excellent prognosis. Okay, thank you. Any question?
No question.
Yeah, any questions?
Betul. The monospot test we do by taking the blood.
Uh-huh. Yeah, it's a blood test.
I see. Okay.
Yeah.
Any more questions?
If there are no questions, then you can just go on to the next one.
Okay.
Sudah. Can you guys see my slide?
Yes.
Yes.
Is it full screen or not?
No, not full screen.
No.
Not full screen.
Cuba tekan F5.
Boleh. Sekejap. Okay. So I'll proceed. So I will explain about the other three virus. Can you guys hear me?
Yes.
Yes.
Okay. So I'll
Yes.
proceed with
Yeah.
other three virus, which are mumps, measles, and rubella. So basically, these are my outline. I will talking about the symptoms, complication, investigation and management, as well as the prevention. So before I go further, let us take a look about these three viruses. Basically, mumps and measles belong to the same family virus which are Paramyxoviridae, but the genus are different. For the mumps, it belongs to rubella virus. For the measles, it belongs to morbillivirus, and these Paramyxoviridae are a spherical and enveloped virus in which at the central, it consists of helical nucleocapsid that contain single-stranded negative sense RNA genome. So from the picture, as you guys can see, the envelope are lined by two important proteins, which are fusion protein and hemagglutinin neuraminidase glycoprotein. These two proteins are responsible for the replication and infection in the host cell. So next, for the rubella virus, also known as German measles or three-day measles, belongs to the family of toga virus. The togaviridae is enveloped with content of icosahedral capsid, in which this capsid contain of single-stranded positive sense RNA genome. So these three viruses cause infections to others via respiratory droplet, in which the saliva content of the respiratory secretion can be secreted via talking, coughing, as well as sneezing. Apart from that, sharing items that contain saliva also can spread the virus by sharing the water bottle. Direct contact such as kissing or hugging can also spread this virus. Lastly, for the rubella, it have another pathway because it have vertical transmission where the affected mother can spread the virus via placenta to the newborn baby. For the pathogenesis, it's very simple. Basically, these three viruses, once been affected, it will infect the respiratory tract epithelium first. Then, it will replicate and go to the local lymph node for lymphatic spread. After that, after the primary viremia, it will infect the reticuloendothelial cell and cause a wide dissemination. For the rest, for measles and rubella, basically due to activation of cytotoxic T cell and antibody that mediates the vasculitis. So I'll go one by one about the clinical symptoms and complication. Firstly, mumps. So the incubation of mum is basically 16 and 18 days. After that, it will have prodromal period, which are non-specific. Patient will have low-grade fever, malaise, headache, and anorexia for 3 to 5 days. After that, it will cause a local swelling of the salivary gland, mainly the parotid gland, known as parotitis. It is 95 symptomatic in a affected child, which means that patients who have been affected with the virus usually manifest as parotitis. It can be either unilateral or bilateral infection due to direct viral infection of the epithelial duct epithelium. It lasts for 10 days, and in this virus, the infectious period basically 3 days before and 4 days after the onset of parotitis, in which once in this period, the patient can easily transmit the virus via respiratory droplet. So this is the picture of parotid swelling. The child will complain of pain at around the ear, or he might complain of pain during eating or drinking. So the swelling is edematous with non-discrete border, and usually it's very painful upon pressure or touch. So for complication, the most common complication is a neurological system, in which it can cause aseptic meningitis and encephalitis. Patient will have the symptoms of meningism or increase in intracranial pressure that present within the first week after the parotitis take place. And it can be diagnosed via the cerebral spinal fluid analysis. But bear in mind that this infection, since it's viral, it carries a good prognosis and most of the patients have complete recovery. Apart from that, it can cause sensory neural deafness due to neuritis of the auditory nerve. Patient with complaint of ataxia, vomiting, or tinnitus. And usually it occurs at the only one side of the ear unilaterally, and it causes transient hearing loss. Next system is reproductive organ, which are the most fearful complication that can occur in boys, which is orchitis, present as unilateral, painful swelling of testes. It is very rare in prepubertal male, and it can also present with gonadal atrophy. But there's one study state that this orchitis rarely cause sterility in male. For female, it can present with oophorytis, which is inflammation of the ovum, but it's very rare because it only presents 7% in the post-pubertal female. Next system is gastrointestinal, when the patient can have acute pancreatitis. It can present with abdominal pain, distension, nausea, vomiting, and been diagnosed with, confirmed with serum amylase. So I've listed other complication, but it's very rare. So this virus is a clinical diagnosis, but investigation can be done to detect the presence of the virus via viral culture. We're using the clinical specimen of urine, saliva, throat swab, or cerebrospinal fluid for mumps meningitis. So the finding of CSF, basically the finding have mononuclear phagocytosis, predominantly lymphocyte with normal glucose level. This presence of viral can be confirmed with serologic test that is raised in serum antibody IgM titer. For the acute pancreatitis, just like I have been told earlier, that it can be confirmed with increase in serum amylase. For the management, since it is an acute self-limiting viral infection, we can offer symptomatic treatment only to relieve the symptoms, such as we can give analgesic as a pain reliever, offer adequate nutrition and bed rest, but there's no antiviral therapy are needed. Second, proceed with measles. So measles have incubation period of 8 to 14 days.
Excuse me, who's watching news? Ada soalan tak?
I have question. Anyone have any question? Okay,
No.
so I'll proceed.
No wait. Somebody's mic is, tunggu jap, Fifa. Somebody's mic is on. Whose mic is on? If you're watching news at the same time, just mute your news for the next like 20 minutes or so. Okay.
Okay, so I'll continue. So after the incubation period, patient will experience high-grade fever for 4 to 7 days, and it also present with 3C symptoms, which are coryza, cough, and conjunctivitis. And apart from that, the patient will have complete spot, which is pathognomonic sign of the measles. This complete spot is usually fade off after the onset of maculopapular rash. For the maculopapular rash, it starts from the hairline and spreads cephalocaudally throughout the body in 24 hours. And then it becomes confluent and lasts for about 5 to 6 days before it fades off. So once it fades off, it leaves a brownish discoloration. For the infectious period, it is 1 to 2 days before and 4 days after the onset of rash. So the patient can transmit the virus during this period via respiratory droplet. So this is the 3C, cough, coryza, and conjunctivitis. And at the arrow I've pointed, there is a complete spot. which located usually in the buccal mucosa opposite the first and second upper molar. So this is a picture of the maculopapular rash at the trunk of the child, and this one at his face. The complication usually occur in child less than 5 years old or adults more than 20 years old. The most common complication of measles are two, otitis media and diarrhea. For the otitis media, it can be due to inflammation of the eustachian tube, or it can be due to secondary bacterial infection of Streptococcus pneumonia or Haemophilus influenza B. Diarrhea can also be one of the complications of the measles. For the serious complication, patient can have bronchopneumonia and encephalitis. So it have drowsiness and altered sensorium. For the long-term complication, patient will have subacute sclerosing panencephalitis, known as SSPE. It's very rare to happen, but it carry high mortality, and once it happens, usually it indicate late neurological complication because this manifestation usually occur after 7 to 10 years once a patient been affected with measles. And usually this is SPE doesn't respond to any treatment. So just like mumps, it is a clinical diagnosis. We can viral culture from the clinical specimen and confirm with the raise in IgM antibody. For the management, we can give supportive treatment like analgesic and maintain adequate hydration. In WHO recommendation, it is recommended that all child that been diagnosed with measles been given high dose vitamin A orally. This is because in one study, it shows that measles cause vitamin A deficiency and can cause ocular blindness. It happened because measles rapid utilize the vitamin A and deplete the vitamin A stored in our body. So once we give vitamin A supplement in the patient with measles, better clinical outcome have been proven. So lastly, the last virus is rubella. For the incubation period is 14 to 21 days, and prodromal period non-specific also like low grade fever, malaise, headache. But the features that are specific to rubella, it have lymphadenopathy at these three most popular regions: post-auricular, post-cervical, and occipital that lasts for 1 to 5 days. After that, there will be the onset of maculopapular rash, start from the face and separate throughout the body in 24 hours that lasts for 1 to 3 days. Infectious period 2 days before and 5 to 7 days after the onset of maculopapular rash. So I have attached the picture so we can see that this posterior auricular, occipital, and posterior cervical region. So the picture is a child being diagnosed with rubella. It have maculopapular rash throughout her body. So the most feared complication for rubella is the rubella congenital syndrome, in which it occurs when the pregnant mother being affected with rubella virus and transmit the virus to her newborn, especially during the first trimester of pregnancy via the placenta. So the baby can either be miscarriage or stillbirth, but if he's able to survive, he will have severe birth defects that are lifelong. So the most common complications are deafness, cataract, intellectual disability, liver and spleen damage, and the baby will have skin rash at birth. So up until now, there's still no cure for the rubella congenital syndrome. That's why it's very important for the woman to get vaccinated before being pregnant. So it is a clinical diagnosis. We can still do a viral culture and confirm with raise in IgM antibody. For the management, it is supportive treatment just like other two viruses. So lastly, I will conclude my presentation. We can take which this vaccine are attenuated vaccine that have two doses. First dose is at 9 months of age, second dose is 12 months, and booster at 7 years. But it is contraindicated for pregnant mother because it is live vaccine that can cause toxicity to the fetus. So that's all from me. Thank you. Is there any question?
Any questions for Afifa? Don't have, say no.
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 Afifa, can you go through your slides one by one? Just from the beginning.
What? Oh,
Can you go through the slides one by one? Just from the beginning. There's one more presenter right after this. Chickenpox, right?
Yes.
Two more.
Two more.
Two more.
Next. Next. Once. Next. Okay, complete spots you can get it in the very beginning, so about the first one or 2 days lah. So you don't see it after that. It's a bit hard to catch. So if you by the time the rash pops out, you wouldn't see a complete spot already. Okay. Okay. Next presenter.
Okay, thank you.
Okay, can you guys see my slide?
Yes.
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 Okay. So my name is Muhammad Najmi bin Zain Anwar, and today I will share with you guys about varicella and herpes zoster. So this is my outline, which include the introduction, pathophysiology, clinical manifestation, investigation, and also the treatment. So basically, of more than 100 known herpes virus, 8 of them are routinely infect only human, and they can be divided into 3 groups, which are the alpha herpes virus, beta herpes virus, and gamma herpes virus. And for today, I'm going to focus on the human herpes virus 3, which is the varicella zoster virus. And little bit about the structure. So varicella zoster virus, they have a unique 4-layer structure. A core that contains the double-stranded DNA genome is enclosed by the capsid, and the capsid is surrounded by the tegumen, as you guys can see in the picture. And then it is encased in a glycoprotein bearing lipid bilayer envelope. This one. And varicella zoster virus can cause chickenpox, also called varicella, and also shingles, also called herpes zoster. Next, we go to the pathophysiology of the chickenpox and shingle. So for the varicella or the chickenpox, the source of the infection of the varicella zoster virus are from the oropharyngeal secretion and in the fluid of the skin lesion and transmitted through the airborne spread or through direct contact. And the primary infection result from the inoculation of the virus onto the conjunctiva, mucosa of the upper respiratory tract, and also tonsillar lymphoid tissue. So during the early part of 10 to 21 days of incubation periods, the virus replicates in the local lymphoid tissue, and then by primary viremia, it spreads to the reticular endothelial system. And during the incubation period, varicella zoster virus transported back to the mucosa of the upper respiratory tract and permitting spreads to the susceptible contacts about 1 to 2 days before the appearance of the rash. And then the second viremic phase, which lasts about 3 to 7 days. And this is due to the function of the host immune system that limit the viral replication and facilitate the recovery. And the peripheral mononuclear cells carry the virus to form new crops of vesicles in the second viremic phase. And after this primary infection, the varicella zoster virus remains dormant in the sensory nerve roots or or in the dorsal root of the ganglion. So that's about the pathophysiology of the chickenpox. Next, we go to the pathophysiology of herpes zoster or shingles. So as I mentioned before, after the primary infection, after the primary infection resolve, the viral particle remain in the dorsal root or any other sensory ganglia, where they may lay dormant for years or decades. And in this latent period, the host immunologic mechanisms suppress the replication of the virus, but the varicella zoster virus can reactivate when the host mechanisms fail to contain the virus. Maybe in patient with immunosuppression. And upon reactivation, the virus can migrate down the sensory nerve to the skin, causing the characteristic of a painful rash. And also if motor nerve roots are involved, weakness can develop in addition to any sensory changes. Next, we go to the clinical manifestation. So for varicella, the varicella, its incubation period about 10 to 21 days, and the illness usually begins about 14 to 16 days after the exposure. The patient can have a prodromal or early symptom 24 to 48 hours before rash, such as fever, moderate fever, malaise, anorexia, headache, and occasionally mild abdominal pain. And then after that, the rash start to develop, and it begin on the scalp, face, and also the trunk. So initially, so this is the picture of the stages of the spot. So initially, the pruritic erythematous macules that evolved through the popular stage to form clear, fluid-filled vesicle and then crusting. And while the initial lesion are crusting, new crops are formed on the trunk and then to the other extremities. And once the chickenpox rash appear, as you can see, it goes through 3 phases, which are raised pink or red bumps, or we call it papules, which break out over several days. And then a small fluid-filled blister or the vesicle, which form in about 1 day and then break and leak. And also the crust and scabs, which cover the broken blister, and it will take several more days to heal. Next, we go to the complication of varicella. I'm sorry. There is it's not compilation, it's a complication. So the complication is rare but can occur, and the most common complication is a secondary bacterial infection of the skin lesion. And other complication includes pneumonia and also neurological complications such as encephalitis. And also in addition, the immunocompromised children, for example, those children that may be receiving chemotherapy for leukemia, or maybe has advanced HIV infection, they can develop disseminated varicella zoster virus infection, which can be fatal. Next, we go to the clinical manifestation of the herpes zoster. So the clinical manifestation of herpes zoster start with the pre-eruption phase of zoster, which includes the intense localized, constant pain and tenderness along the affected dermatome. And this is also accompanied with malaise and fever. Then this followed by acute eruptive phase. In this phase, the patient may also experience some of the symptoms that are seen in the pre-eruptive phase. And the lesion begins as erythematous macules and papules that quickly develop into vesicles. And after they form the vesicles, the lesion progress through the stage, and then they rupture, release their contents, ulcerate, and finally cross over and dry. The growth of lesions occur for about 1 to 7 days and progress to crusting and healing. And also the reactivation of the varicella zoster virus in the shingles also can involve the cranial nerve. For example, like it can involve the trigeminal, the fifth cranial nerve, and also the facial nerve. So for example, the reactivation of the varicella zoster virus involving the facial nerve and the auditory nerve can cause the Ramsay-Hunt syndrome, which may cause facial paralysis and hearing loss in the affected ear. Next is the complication for the herpes zoster. So for the complication, it includes, as mentioned before, Ramsay-Hunt syndrome, if it involves the facial and also the auditory nerve. And the second is ophthalmic zoster, which occur due to the activation of the varicella zoster, which involve the trigeminal nerve. And it is a shingle involving the eye. And the symptom generally include rash of the forehead with swelling of the eyelid. And there may be also eye pain, eye redness, and light sensitivity. And the third one is post-herpetic neuralgia, in which the pain is persisting for more than 30 days or 1 month. but however, it is uncommon in children. Next is investigation. So the clinical presentation of the varicella or zoster are so characteristic that laboratory confirmation is rarely required. However, the investigation may require for a typical presentation, particularly in immunocompromised patients. And the laboratory investigation for the varicella zoster virus includes the direct fluorescent antibody testing of the vesicular fluid, polymerase chain reaction testing of vesicular fluid, and also I'm not sure how to spell it, but how to pronounce it, but it's spelled as T-Zen smear, in which they will scrape the ulcer base and to confirm this to confirm it. Next is the treatment. So basically, this disease is self-limited and usually requires no treatment. However, they tend to be more benign and mild in children than adults. So the symptomatic treatment of the varicella include the non-aspirin, antipyretic, and also practice good hygiene. Also, antiviral therapy can help to decrease the length of the time for the new vesicle formation, the number of days to attain complete crusting, and the days of acute discomfort. So early treatment, for example, with acyclovir, is given to the immunocompromised patient and those who are at risk of severe varicella. And then varicella zoster immune globulin is indicated for administration to high-risk individuals within 10 days of chickenpox exposure. And the high-risk groups which include immunocompromised children and adults, premature infants, or maybe a pregnant woman. And also I've read that why in the treatment, it said that it use non-aspirin because non-aspirin antipyretic is because the use of the aspirin in children with chickenpox has been associated with Ray's syndrome, a severe disease that affect the liver and brain and can cause death. So instead we can use non-aspirin medication, for example, acetaminophen, to relieve the fever. And okay, and that's all. Thank you.
Lakshmi, just now the smear is a sang smear, is it? You were spelling T-Z-A-N-C-K, is it?
Yes.
Sang smear.
Sang smear.
Yeah, it's basically just a scraping of the ulcer to see what it is, isn't it?
Yes.
I think you guys want to ask Lakshmi now.
I have a question. Regarding varicella, is varicella pneumonia a common complication in pediatric patients?
Sorry?
Is varicella pneumonia a common complication in pediatric patients?
I'm not sure, but as I mentioned before, the complication in children is rare, but the most common complication is the secondary bacterial infection. But for the pneumonia, I'm not sure it is more common or uncommon.
Do you mean pneumonia or pneumonitis? The
Pneumonia, right?
person will ask, you mean pneumonia or pneumonitis?
Pneumonia, varicella pneumonia.
You want to know how common it is it? About 8%, 5 to 8%. It's varicella associated pneumonia.
Okay. Thank you, Doctor.
Doctor, I have another question, but I want to ask Doctor instead. Is it true that acyclovir is prescribed to patient with Charlie's rash? Charlie.
Can you spell that?
Charlie insect. You know, ulat Charlie.
Can you spell it?
Charlie.
I don't know. This is in relation to what?
Huh?
This is in relation to what?
Usually, patient with Charlie rash, the presentation is similar to shingles, from what I understand lah.
Are you sure the spelling is correct?
Charlie.
Because I've not heard of it before.
Charlie's N.
Charlie's N.
Due to Charlie's N.
Sorry?
The rashes is because mainly due to Charlie's N. Charlie N.
Can you spell it?
Charlie, CHARLIE, ANT, N. Semut.
It's literally an insect, is it?
Yeah, it's an insect.
I have no idea. But usually we wouldn't give an antiviral for an insect bite, isn't it?
Supposedly.
I mean, if you think of it rationally, you wouldn't give an antiviral for an insect bite.
Okay.
I lately got something about Charlie ants on the net no, that's 2 years ago. Okay. Any other question?
No, Doctor.
Okay, thank you.
Quantities of the beetles on the residents. Dermatitis.
May I start? Okay, Bismillahirrahmanirrahim. My name is Fatina Jiha and I will continue our last group presentation with the topic of hand, foot and mouth disease. So before I start, this is my outline. So I will cover on the definition, the etiology, the epidemiology, the mode of transmission, the clinical features, complication, diagnosis, investigation, treatment, management, and prognosis. So first, what is hand, foot, and mouth disease? Hand, foot, and mouth disease is typically a benign and common illness among children and infants characterized by rapidly ulcerating vesicle in the mouth and lesions. And usually it is vascular on the hands and the feet. So hand foot mouth disease is caused by the enterovirus genus such as poliovirus, Coxsackie virus, and ecovirus. So the most common causes of the hand foot mouth disease is the Coxsackie virus A16 or the enterovirus 71. So this hand foot mouth disease, the incubation period is usually between 2 to 7 days. So a little bit info for the two most common causes, which is Coxsackie virus A16. It is frequently encountered pathogen, and it may cause an eventful clinical course, and full recovery is expected. And it can also causes more generalized involvement and severe systemic symptom. And for this Coxsackie virus, the fatal cases are rare. The other common causes of the hand foot mouth disease is enterovirus 71. So it is more severe and complicated with the meningitis, the encephalitis, and neurogenic, and also pulmonary edema. So this enterovirus can cause death, and it usually can cause fever more than 39 degrees Celsius and longer than 3 days. So next, the epidemiology. Hand foot mouth disease is an endemic disease in Malaysia. And first Malaysia outbreak occurred in Sarawak in 1997 and latest outbreak in 2018, which highly affected the Selangor, Kuala Lumpur and Sarawak. And in 2019, which is last year, there is the decline cases in hand foot mouth disease, about 31.6%, with the Sarawak the highest cases, followed by Selangor and Sabah. And hand foot mouth disease commonly affected the age group between 6 months old and to 5 years old. So basically, hand foot mouth disease, the children under age 5 is more susceptible due to the lower antibody and lower immunity against infection. So it is very common for hand foot mouth disease outbreak in the kindergarten, where the children are unlikely to have good hygiene practice. You know, they often put toys into their mouth and share the toys. So the spread of the disease from child to child is a lot easier. But it can also affect the adult. So fortunately, the hand foot mouth disease is usually a mild disease, and rarely children suffer from the serious complication. However, it is a concern because enterovirus 71, which caused the hand foot mouth disease, has become an important public health disease due to its tendency to cause large outbreak and death among the children and infants. So next, we come to the mode of transmission. Hand foot mouth disease is moderately contagious, and a person is most contagious during the first week of the illness. So the infection can be spread from person to person by the direct contact with nose and throat discharge, saliva, fluid from blister, or the stool of infected person. And also it can be spread by the aerosol droplets when the person cough or sneeze, and also the contaminated format such as object and surface such as utensil, clothes, and others. So for the after we have a direct contact to the infected person, so there is an initial viral implantation in the buccal and ileal mucosa, which followed by the spread to the lymph nodes within the 24 hours. So the viremia which rapidly ensues, and then we spread to the oral mucosa and skin. So by day 7, the neutralizing antibody level increase and the virus is eliminated. So it is a self-limiting disease. So next, we go to the signs and symptoms. So hand foot mouth disease can cause mouth sore, skin rash or flat red spot that may blister at the hands and feet, the fever, sore throat, loss of appetite, malaise, headache, conjunctival infection, abdominal pain, and diarrhea. So next, we go to the clinical feature. There are two clinical features that we can see in this hand, foot, and mouth disease, which is oral ementem and exanthum. So oral inantum is a rash or small spots on the mucous membrane, which is occur most commonly on the tongue and the buccal mucosa, and less commonly on the gingival labral groove, soft and hard palate, uvula, lips, and tonsil. So this begins with as the erythematous mercule, which progress to vesicle surrounded by a thin halo of erythema, like this picture. And then the vesicle quickly rupture and form the superficial ulcer with a grayish yellow base and erythematous rim, like this picture. Okay, next, the exanthum. So exanthum is a widespread rash occurring on the outside of the body. So it can be a maculopapular or vesicle, but usually it is vesicular. So the vesicle is a thin wall, contain a clear or turbid fluid, and are surrounded by a thin halo of erythema. And it involves the hand, the dorsum of the finger, the interdigital area, and the palms. For the feet, it can involve the dorsum of the toes, the lateral border of the feet, soles, and heels. And also it can involve the buttocks, the legs, the upper thigh, and the arms. And less common site for the exanthum occur, it is torso and face. So there is a complication for the hand, foot, and mouth disease, such as a decreased oral intake due to the painful ulcer, which may lead to the dehydration. And others, usually neurological complications, such as rhomboencephalitis, which is brainstem encephalitis, acute flaccid paralysis, and aseptic meningitis. These three can be caused by the enterovirus infection. So the diagnosis. So how to diagnose the hand, foot, mouth disease? Hand, foot, mouth disease is usually a clinical diagnosis, and the laboratory investigation are usually needed in establishing the diagnosis. So if you want to do the laboratory studies, we can do the culture and immunoassay. So we take the sample from the lesions of the cutaneous and mucosal or the stool sample. For the vesicle, we can use the vesicle swab, you can look at the picture. And in patient without this vesicle, we can do the rectal swab. And then we may also use the PCR and microarray technology, which to differentiate Coxsackie A16 virus from the enterovirus 71 for prognostic purposes. So next, the treatment. Hand, foot, mouth disease is usually mild and self-limiting, and most cases it doesn't need the admission but managed as outpatient. And most fatal hand, foot, mouth disease cases is due to enterovirus infection, as I told before. And the treatment for the hand, foot, mouth disease is supportive treatment. So it is symptomatic. So what we do is we give the antibiotic for fever, and we can increase the fluid intake, and we can give the intravenous hydration for the moderate to severe dehydration or discomfort for the oral intake. And cold drinks are preferable to reduce the inflammation. And also we can give the acetaminophen and ibuprofen for pain. And direct analgesia can also be applied to the oral cavity via mouthwash or sprays. And this next, we can go to the criteria for the hospitalization for the serious cases. If the patient cannot tolerate to the oral intake, if the patient is clinically very ill and toxic looking, if there is persisting hyperparesia, which the temperature is more than 38 degrees Celsius for more than 48 hours, and if you suspect there is a neurological complication, such as the patient may appear lethargic, there is myoclonus, drowsiness, change in sensory and seizure, and if you suspect the patient having cardiac complication, such as having low blood pressure, low pulse volume, murmurs, and displaced apex beat, and also if the parent unable to cope with child's illness, and if there is inadequate family and social support to take care of the child, we can hospitalize the patient. So next we go to the infection control. So this infection control is for the hospital purposes. So for the infection control, we need to practice a proper hygiene, including mandatory hand washing after contact with patient, and appropriate cleanliness during diaper changes is imperative. And also personal items such as spoons, cups, and utensils should not be shared and should be properly washed with detergent after use. And also the use of gown may act as a useful protection for health personnel looking after this patient. And patient with hand foot mouth disease should be isolated, and the usual isolation procedures followed for infection control. So as a preventive measure at home, we can also prevent this hand, foot, and mouth disease by avoid close contact with sick people, cover when we cough and sneeze, with having a frequent hand washing with soap and water, and also we clean and disinfect the surfaces such as our toys, eating utensil, and toilet floor. And stay at home if you are sick. Also, we avoid to touch our face with unwashed hands and eat nutritious and balanced diet. So, and last but not least, the prognosis. So the prognosis of hand, foot, mouth disease is an excellent. So vast majority of patients are expected to recover fully, but except for the cases with there is more serious complication. So there is no vaccination against the hand, foot, mouth disease. And if you have any question, if you think will this hand, foot, mouth disease will occur again, so if we get infected, so we have the immunity to only one particular strain of the virus. So if we get, but we can still get infected by another strain within the same family of the virus. So good personal hygiene must be practices. So this is my references, and thank you. Is there any questions?
Okay, going back to the person who asked about the Charlie's ant just now. Charlie's ant is a rove beetle, right? You wouldn't give antivirals for insect bite, right? The person who asked about encyclopedia just now?
Yes.
So you wouldn't give antiviruses for an insect bite. I think that some people misdiagnose, that's why they give acyclovir, I think, because the insect bites can present as a dermatitis, or it can look as like blisters, right?
Yes.
But you wouldn't give acyclovir for the insect bite, for the roof beetle thing.
Okay.
Now, hand, foot, mouth. Can you start from the? Just show me the first slide. Just go down. Wait, turn back the picture. No, one more slide back.
This one?
Back. No, the one before this one. No, before. Yeah, this one. Which part of the slide? Just now that slide. The other one.
Okay.
No, the one that comes after. Yeah, this. Now they always say hand, foot, mouth, right? But it's not just the palms. Usually you find them on the palms and the soles of the feet. But sometimes you also get it on the extensor surfaces of the knees and also the elbows. Kind of like the ones at the bottom, the two pictures at the bottom. So don't be like confused if suddenly the distribution is like that lah. But that's a thigh actually. But sometimes you can get it on the elbows there and also the knees. not just on the hands and feet. Next. Next. Okay. Now the whole topic is actually basically is your differential diagnosis for any fever with rash, isn't it? So it's important that you guys know what rash is associated with which disease, and also the progression of the disease. Like in measles, the rash is from the head down to the body, down to the limbs, and then you get a post-measles staining, and then things like chicken pox, these different crops of different ages at the same time, then how the different crops look like. All of these diseases are actually self-limiting, but many of them have severe complications. That's why it's important to get vaccinated and immunized against the ones that have a vaccine, against the diseases that have vaccine. So you have the MMRs. It's not enough to say that, measles, no big deal. Lots of kids get it. Lots of kids, it's nothing. After a few days, it will be better. But then many of these kids also get complications, and if they get complications like encephalitis, very bad pneumonias, and they end up in the hospital and end up with long-term complications, that's not worth missing out on your vaccination just because you feel that it's not a severe disease. It might not be severe for you, but it might be severe for another person. You're not going to risk a complication on the child when it's easily preventable. Okay, any questions for the topic?
No, doctor.
Yes. Don't have, then we can just, that's all right?
Yes, that's all.
Okay. Try again. Okay, if that's all, then I'll see group 3 on Thursday, right? 2 p.m., right?
Yes.
See lah, I'll rustle out something for you guys. Okay.
So doctor,
Hmm?
so for this Thursday, we're gonna do like problem-based learning, is it?
I'll see lah. Either a problem-based learning, or let you guys watch a video on how to examine patients. Probably a little mix of everything lah.
Okay.
So this is how many of week? This is the how many of week of your posting?
Week 7.
Week 7. So no clinical work at all for the past 7 weeks lah.
Yes.
Okay. So wait, now it's what? Now it's posting pertama ke ni? Or is it your last posting of the year?
The third one.
Posting.
Third posting.
Third posting because you break in between, right? 2 months, right?
Yeah. Yeah.
So
Pediatric posting first 2 weeks saya tu dah masuk hospital lah. First 3 weeks.
First 3 weeks. And then cuti.
First 3 weeks je lah. Lepas tu cuti.
Lepas tu cuti.
PKP.
Okay. See how it goes. Probably you guys watch a video and a bit of explanation, and then I show you guys how to the examination videos, and then you'll see how it goes.
All right.
Okay. All right.
Doctor. Okay.
Okay. Bye-bye.
Okay,
Bye.
bye. Thank you, doctor.
Thank you, doctor.
Thank you, doctor.
Thank you.
Thank you, doctor.
Okay.
Thank you, doctor. Bye.
Thank you, doctor.
Bye.
Mana lift on?